Okay, now we are going to take a look at the different drugs that we use in shock. So we are going to take a look at inotropic drugs and also the vasopressive drugs. To study them, it is very useful to briefly notice how the myocyte contracts and works. Here I'm going to try to draw. This is a myocyte, and we have already seen it in other lessons how the action potential comes to the myocyte and it opens one channels of calcium. So when the action potential comes, the calcium enters inside the myocyte. When it enters, here we have the sarcoplasmic reticulum that senses the entrance of calcium by one receptors that are the ryanodine receptors, senses this calcium and release more calcium that they have inside. More calcium is released. Then this calcium, when it's in the myocyte, it joins to the troponin C. When they join, it makes that the tropomyosin that is in the middle of actin and myosin, it removes from, so it allows actin and myosin to connect and start the contraction. So it is basically how it works, the entry of calcium and the contraction in the myocyte. So what do we have? We have that a lot of the inotropic drugs that we use, they work to here. They work in what is called the beta-1 receptors. The beta-1 receptors come here. When we activate these beta-1 receptors in the myocyte, what they do is that they increase the cyclic AMP, the cyclic AMP, and by this way they stimulate the release of more calcium from the sarcoplasmic reticulum, and by that way they increase the calcium and they exert the positive inotropic effect, enhancing the contraction. So by that way they have a positive inotropic effect. But well, they also not only goes to the myocyte, they also go to the pacemaker cells. The pacemaker cells of the heart, they also promote an entrance of calcium in those pacemaker cells, and as we have seen in other lectures, this increase the slope of the phase 4 of the action potential in those pacemaker cells, and in that way they increase the heart rate. So they have also a positive chronotropic effect. So that's the way they increase the stroke volume. They increase the heart rate, and that way is how the inotropic acting in the beta-1, they increase the cardiac output. So there is one problem with the drugs that act by this receptor, is that first they function due to increase in the calcium. The increase of calcium also, as we know, promotes arrhythmias. Why? Because this increase of calcium is produced not only early after the polarization, also delayed after the polarization, and also abnormal automatism. So this increase of calcium produces arrhythmias, and all the drugs that we are going to see that act by this beta-1 can lead to the arrhythmia production. So we must say that all those drugs not only act in the beta-1 receptors, some of them they also act in the beta-2 receptors. Those beta-2 promote the release of calcium in the smooth muscle cells, and it leads to vasodilation and bronchodilation. Some of them they also act in the alpha receptors. When they act in the alpha receptor, they produce the opposite, vasoconstriction. Okay, this is something that we have to take into account. So we are going to see one by one. Remember, those first four are the ones that act in the beta-1. They are inotropic. So let's start with dobutamine. Dobutamine is an inotropic that, first of all, it mainly acts in the beta-1. They also act in beta-2, but less than in beta-1, and also acts in alpha, but also less. So when we give a patient dobutamine, it's because we have to think about the beta-1. We want to enhance the stroke volume and the heart rate. Okay, but because they act mainly in beta-2, they produce vasodilation. They act in the alpha but much less, so it produces vasodilation. Well, the two things that we have to remember about the dobutamine is that they produce, like all of them, increasing cardiac output because it's the inotropic effect, but also it produces vasodilation. Okay, the next one will be norepinephrine. Norepinephrine mainly acts in the alpha receptors. They also act in the beta-1 because it is like all of them, but we have to remember that they mainly act in the alpha receptor. So when we think about norepinephrine, we have to think that it produces vasoconstriction. Then here comes epinephrine. When we think about epinephrine, we must say that it acts in beta-1, in beta-2, and in the alpha ones. So it produces mild vasoconstriction, not as strong as norepinephrine, but when we give epinephrine, we mainly give because of the beta-2 receptors. When we think about epinephrine, we have to think about the beta-2 receptors. We will mainly use epinephrine in patients with anaphylactic shock or asthma because we want to produce this bronchodilation that the beta-2 produces. Also, we can also use epinephrine in some other circumstances, like for example, when we are going out of an external circulatory system after a cardiac surgery and the myocardium is stunning, but mainly we are going to use it in the setting of anaphylaxia or asthma. Okay, and dopamine. Finally, dopamine, the last one of the beta-1 inotropic. Dopamine is special because it's depending on the doses that we are given. We are going from one receptor to another. If we give low doses of dopamine, we will have less than 3 milligrams per kilo, then they have a mild vasodilatory effect mainly in the renal flow. Although this is a little bit controversial in critical patients, we can say that if we increase the doses, then we will get this beta-1 effect that we have in any of the other. After we continue increase, then this is between 3 and 5, and if we go above 5, then we are going to have the alpha effect. So with dopamine, we got that we can go from a mild vasodilatory effect to the vasoconstrictor effect. Okay. So, which problems do we have with patients with this that activate those beta-1 receptors? Well, we have, apart from the arrhythmia problem that we have already mentioned because of the calcium concentration, we have another 2 problems, and it's that we cannot give them in patients with beta blockers. Patients that are already on beta blockers, we cannot, because we are not going to be able to stimulate those beta-1. And the second one is that they have what is called a tachyphylaxia. Tachyphylaxia means that if we stimulate this receptor for so long, they lose the effect. So if we keep a patient for a certain time using those kind of drugs, in the end they will lose effect after a certain period of time. So we have to look for another different inotropic agents that have another route to act. We have another route, in fact, here, that, which you remember, we have here the cyclic AMP. This cyclic, there is one enzyme that is called the phosphodiesterase 3. This enzyme turns the AMP3 into the cyclic AMP into AMP. So this enzyme degrades the cyclic AMP. So we have one agent that inhibits this enzyme, and by the inhibition of this enzyme we manage to increase cyclic AMP and therefore increase calcium and have the inotropic effect. This is milrinone. Milrinone is a phosphodiesterase 3 inhibitor. Inhibit this phosphodiesterase and then increase the levels of AMP. Therefore, with milrinone, we can give it in patients with beta blockers and doesn't have the tachyphylaxia effect. Milrinone also increase the cyclic AMP levels in the smooth muscles and also produce huge vasodilation, even more than the butamine. And finally, we have another inotropic agent that is going to bypass this problem that we have already mentioned. We have already mentioned that the store of calcium inside the myocyte is negative because it produces arrhythmia. So what levosimendan does, it stabilizes here the joining between calcium and troponin C. So it acts in the complex of troponin C calcium. By this way, it manages to increase the contraction with the same amount of calcium. And it leads to less production of arrhythmias. Levosimendan also produces vasodilation. Okay. And finally, we are going to separate these two. And finally, we are going to mention two vasopressors. Those are vasopressors. That means that phenylephrine and vasopressin, the ones that we are going to mention now, they are not inotropic agents. They do not enhance cardiac contraction. They only produce pure vasoconstriction. So, when we produce pure vasoconstriction, if we increase systemic vascular resistance with either of those two, I'm going to mention that phenylephrine is pure alpha agonist and vasopressin acts in the vasopressin 1 receptors. Both of them produce huge vasoconstriction. We do not use them very often in the setting of shock, mainly because if we increase the systemic vascular resistance, the body compensates with a reflex, lowering both heart rate and stroke volume, and it decreases cardiac output. And this is something that we don't want in a patient with shock. However, sometimes when we have a patient mainly with distributed shock, a patient in which we have already given another inotropic drugs and we want a more powerful vasoconstrict effect, we add some of those two, phenylephrine or vasopressin, but it's not very often. So, to summarize, what can we say about the treatment of shock? Once we decide that we have a patient with shock and we have detected that this patient has, for example, an hypovolemic shock, the treatment of hypovolemic shock will be to give IV fluids and trying to correct any of those causes. If we have noticed that the patient has a cardiogenic shock, obviously we have to rule out any of the causes, either mechanical, obstructive or primary cardiologic, and we have to treat them. But also we have to decide whether we want to use diuretics or not. If we decide that the problem is in the left heart because we have pulmonary congestion, in this setting, if the blood pressure is not too low, we will give diuretics. And we have to also, because we have a low cardiac output, we have to decide which inotropic are we going to give. Well, if the blood pressure is not bad, if the blood pressure is not too low, we will be able to give, for example, dobutamine as the first election, or if the patient is with beta blockers, then we will be able to use milrinone or levosimendan. Okay, but the two that we use more often are the dobutamine and levosimendan. But if the patient has low blood pressure, we have to be very careful because any of those produce vasodilation, and in this setting, if the pressure is too low, probably we are going to give either norepinephrine or dopamine at high doses because they have a vasoconstricting effect. Okay? And finally, if we decide that our patient has, say, okay, here inotropics, a distributed shock, depending on the cause, if the patient has sepsis, or central nervous system injury, then we will probably give the patient norepinephrine. In sepsis, is the drug of choice, norepinephrine. But if the patient, the cause is anaphylaxia, then we will probably give epinephrine. If in this setting of a distributed shock, the vasoconstrictive effect of any of those drugs is not enough, then we will be able to add a pure vasoconstrictor like phenylephrine or vasopressin. And that's all with the treatment of shock. Thank you.